Okay, so welcome everyone to today's webinar hosted by the Neonatal Hemodynamics Research Center. We are delighted to have you join us for what promises to be an enlightening session on insights into cardiovascular adaptation in the delivery room. I am Poorva Deshpande, one of the neonatologists at Mount Sinai Hospital in Toronto, and I will be one of the moderators for today's session. Also co-moderating with me is Dr. Carolina Michel, who is a neonatologist in New Mexico. I am honored to introduce our distinguished speakers today, Dr. Neidin Bussmann and Dr. Eugene Dempsey, who will be exploring this fascinating topic, and we are fortunate to have them share their knowledge with us today. Dr. Bussmann and Dr. Dempsey are consultant neonatologists at Cork University Maternity Hospital. Dr. Dempsey is also the clinical lead for neonatal research at the Infant Research Center at University Cork College. I would also be introducing our panelists. So we are fortunate to have an esteemed panel of experts who will be contributing and enriching our discussion. So firstly, I will introduce Dr. Sharada Gowda, who is a neonatologist with cardiac critical care training, and she's an assistant professor of pediatrics in the Division of Neonatology at Baylor College of Medicine. Her academic interests include management of congenital heart disease and mechanical circulatory support. Then we have Dr. Anup Katheria, who is an associate professor in pediatrics and the director of the Neonatal Research Institute and the NICU Follow Clinic at Sharp Mary Birch Hospital for Women and Newborns. He has conducted a number of clinical trials in the delivery room, such as cord management, caffeine and Lisa use, as well as hemodynamic monitoring. We also have Dr. Tina Leone, who is an associate professor of pediatrics at Columbia University and a neonatologist at the Morgan Stanley Children's Hospital of New York. Her academic interests include neonatal resuscitation and transitional hemodynamics. And last but not least, we have Dr. Willem de Boode, who is a pediatrician neonatologist at the Amalia Children's Hospital. He is the president of the European Society for Pediatric Research, and his primary areas of expertise include neonatologists perform echocardiography, advanced hemodynamic monitoring, PDA, neonatal shock, and extracorporeal life support. So before we begin, let me briefly outline the format of our webinar. So firstly, our speakers will present their topic for about 30 to 35 minutes, after which we will open the floor to questions from our audience, and we will have some insights from our panel. We encourage everyone to use the Q&A chat box if you have any questions throughout the presentation. So without further ado, let's begin the exploration. So Dr. Bussmann, the floor is yours.
Thank you very much, Dr. Poorva. So first of all, thank you to the NHRC for giving us the opportunity to present from Cork this evening. It is Cork here at the moment. I know it's different times all over from where everyone is logging in tonight. So this topic is very much on trend at the moment, and it follows on nicely from a presentation given by Dr. Anup Katheria in just at the end of 2023 on this forum. And I would encourage everyone to review this on the YouTube channel to gain further benefit from today's talk. So we are going to focus on insights into cardiovascular adaptation in the delivery room. And hopefully, as Dr. Poorva has said, this will open up an interesting discussion with our panelists and with you, the audience, this evening. So just to lead us through the talk tonight, we're going to just look briefly at transitional circulation just to remind ourselves, and then look at the research assessing cardiovascular adaptation in the delivery room, specifically at animal studies, both term and preterm infant studies, physiological-based cord clamping, and finally looking at non-vigorous infants. And finally, we will look at the considerations that we might take from all of this research. So just to begin, this is just a small little sketch looking at the fetal circulation. And what I would like to draw everybody's attention to really is the pathway that the oxygenated blood takes from the placenta through these following shunts. So we can see here it moves through the ductus venosus from the umbilical vein to the IVC and into the right ventricle, and then through the second shunt through the foramen ovale along the ridge of the eustachian valve, up into the left atrium, and from there on it gets pumped out into the aorta. Now here, just at the ductus, the blood is going to be transferred from right to left because of the pressure difference in utero. So we have some blood then which is less oxygenated, causing more of a medium oxygenated blood to the lower body, whereas the upper body will have the higher oxygenated blood. And it's really more the shunts that I wanted to just remind everybody of and where exactly they are. So looking at how this fetal circulation changes to neonatal circulation with spontaneous respirations. So as we know, the baby will take a deep breath in, hopefully inhale oxygen, the liquid is replaced by air, and we get a reduction in the right ventricular afterload. As well as this, we get increased pulmonary blood flow, and we get left to right flow from the aorta into the pulmonary artery, thus increasing the blood return to the left ventricle and increasing left ventricular preload. At the same time, as the placenta is still attached, the LV afterload is also relatively low, and we have an ongoing placental transfusion occurring secondary to gravity and uterine contraction, negative intrathoracic pressure, intrinsic cardiac activity, as well as spasms of the umbilical arteries. But what happens when there is no spontaneous respiration? So we have no inspiration, poor pulmonary blood flow, we have a maintained high RV afterload, and as discussed, we don't have that increase in LV preload. If the cord is clamped immediately in a baby without spontaneous respirations in order to initiate ventilation processes, there's also an ongoing issue of a low RV preload and a sudden increase then in the LV afterload. And overall, this reduction in the LV preload and increased LV afterload can result in a reduction in the cardiac output. So let's look a little bit at what studies in the past have shown us. So this study, this animal study from Bhatt et al. Dating from 2013 is probably one of the most important papers in the last decade, which highlights the impact of initiating effective ventilation prior to clamping the cord in preterm infants. So in this group, there was one set of lambs who underwent an immediate cord clamping and were then ventilated 2 minutes later, whereas the second group were ventilated first with the cord intact and only had the cord clamped once the pulmonary blood flow increased and the pulmonary pressures reduced. So in this picture here, just to help everyone follow through this image. So this is the unventilated or clamp first group, and this is the ventilated group. So it's representation really of 2 preterm lambs undergoing either immediate cord clamping with subsequent ventilation at 2 minutes, or ventilation first and then cord clamping once pulmonary blood flow has increased. So I want to draw your attention to the unventilated lamb. There you can see that at cord clamping, so this dotted line going down here, you can see that there's a spike in carotid arterial pressure as well as carotid blood flow. And there's a spike in pulmonary arterial pressure, which is then associated with a reduction in pulmonary blood flow and bidirectional flow in the ductus arteriosus. Whereas in the ventilated lamb, we can see no spikes in the carotid pressures or the carotid flows, as well as the pulmonary blood pressure, and the pulmonary blood flow also remains consistent. And we can see that the ductus arteriosus flow is trending towards left to right. And this highlights a smoother cardiovascular transition in lambs who are ventilated prior to cord clamping. And this is really what started it all. So if you look at this image here, we can see that these graphs basically signify the entire group of lambs. So all 12 lambs with 6 in each group. We can see again that there's a smoother transition in the pressure within the carotid artery, the pulmonary system, as well as in the carotid flow and the pulmonary blood flow. There is a reduction in right ventricular output in both groups, but we can see that here, this top group, the right ventricular output is only reduced by 22% maximally, whereas it's reduced by 65% in the unventilated group. So this is from when the cord is clamped to 2 minutes of age, or 2 minutes after cord clamping, apologies. And what we can see here is that this smoother cardiovascular transition persists. We've got a higher pulmonary blood flow and right ventricular output in the ventilated group, and that persists up until 30 minutes of age. So another lamb study by Brower et al. In 2020, similar to the BATS lamb model, showed that pulmonary blood flow increased as breathing continued, and they could identify a smooth cardiovascular transition. So what they were trying to do is show the effect of spontaneous breathing on umbilical venous blood flow and placental transfusion using delayed cord clamping in preterm lambs. However, there was no increase in weight gain, which was their primary outcome, to show that inspiration or negative intrathoracic pressure increased the flow from the umbilical vein. So although they weren't able to show their primary outcome, they did show that these babies also had a smoother cardiovascular transition, similar to the BAT cohort. Now, when the same group then looked at spontaneously breathing infants in 2022, they echoed 15 spontaneously breathing term infants with their cord intact, and they looked at the flow in the ductus venosus, in the hepatic veins, and in the IVC. And what they noted was anterograde flow in the ductus venosus and hepatic veins in inspiration, and retrograde flow in expiration. And the IVC collapsed. However, this collapse occurred caudal to the ductus venosus, and so it didn't affect the UV flow during inspiration. So this shows the anatomical difference between lambs and infants, and that spontaneous breathing possibly is a greater driver for placental transfusion than gravity and uterine contractions, which is something that other studies have shown as well. Now, in keeping with the topic of flow, in 2015, Boore assessed umbilical blood flow patterns directly after birth, but before delayed cord clamping. There was 30 infants included, very simple umbilical cord ultrasound that followed an SVD before cord clamping. There was 50 seconds of flow recorded in the UV and 50 seconds of flow recorded in the UA. So what we can see here is this prolonged period of blue, which is blue is towards the baby. And what we can see that this is during the baby taking a deep breath in. Now here we can see the baby is crying. So we have a shorter period of inspiration in blue and a longer expiration period as the baby is crying out. And in that stage, the flow is actually going away from the baby. And it was also noted in this study that flow continued after pulsations had stopped, and that the UA flow can continue after the UV flow discontinues. Continuing on with flow, Crosley et al. In 2009 had looked at dynamic changes in blood flow through the ductus arteriosus at birth. And in this animal study, the team identified changes in the flow in the pulmonary artery in fetal life before cord clamping, and in the neonate at 5 minutes and 1 hour after cord clamping. They noted the presence of anterograde and retrograde flow in the pulmonary artery in fetal life, and then pulmonary blood flow increased after birth following a drop in the pulmonary arterial pressure. Flow across the ductus arteriosus is also right to left in fetal life, as we can see here, but then it switches left to right, which also reflects the drop in pulmonary pressures and an increase in pulmonary blood flow. In another study by Brower et al. In 2021, which was an ancillary study to the aeration, breathing and clamping trial ABC 2 and 3, Brower et al. Noted that at 1 hour of age, the flow across the ductus arteriosus in their 16 preterm infants that were included was predominantly left to right. And this is just to highlight the consistency with findings in preterm lambs as well as term infants. Now, we've looked at some animal studies investigating the effect of breathing and cord clamping on transition, as well as changes in flow patterns around breathing and cord clamping in both human and animal studies. Let us now turn to a study carried out in Cork, which investigated the impact of cord clamping on hemodynamic transition in term newborn infants. The study objectives were to non-invasively monitor the transition from fetal to neonatal circulation and to measure the cardiovascular changes following cord clamping. So this was carried out in the maternity hospital in Cork. All babies over 37 weeks gestation undergoing an elective section were included, and those excluded were babies who had a contraindication to delayed cord clamping, had congenital heart disease or chromosomal anomaly. And just to point out that there was 3 time points at which the echo was carried out. The first was immediately after birth. The second was immediately after cord clamping, and the third was at approximately 5 minutes of life. So I'm just briefly going to show some short videos at each of these time points. So here we have video number 1. This is at time point 1. We can see that our research fellow, Dr. Camero, is completely gowned up and is sterile. The obstetrician is here stimulating the baby while the echo is being carried out, and it's very feasible to carry out this echo and carry out the measurements that were carried out. In time point 2, we can see that the baby is still crying. Everything is going very well. And what's going to happen is we're going to come in here, clamp the cord very, very smoothly. Baby is nice and pink. Lots of crying and moving around happening here, and Roberta will immediately jump back in again to carry out the echo at the second time point. So as said, immediately after the cord has been clamped. The third time point is when the baby is 5 minutes of age, and this was usually performed on the open resuscitator that we have in all of our delivery theatres. So we can see here, Dad is also involved in this. He is beside the baby, comforting the baby, and there's no issues carrying out this echo either. So moving on to what babies were included. So there was 86 babies that were eligible for this study during the study period, and 46 were finally included following the consenting process. So looking at some of the results from the study. So just to highlight that any asterisks on these slides here identify statistically significant results. So time point 1, this is, as said, directly at delivery. Time point 2 is directly after the cord is clamped, and time point 3 is at 5 minutes of age. So I want to draw your attention to the right ventricular output. So it reduces at this time point here, just directly after the cord is clamped, but by 5 minutes of age, when this echo is carried out, the right ventricular output has increased as well. Similar to this, the right ventricular stroke volume drops off after cord clamping, but increases again at 5 minutes of age. We also see that PATI drops from delivery to immediately after cord clamping, and PATI is inversely related to pulmonary arterial pressure. So essentially we see a climb in pulmonary arterial pressure directly after the cord clamping, which then reduces again to where it was at baseline. There was also a consistent climb in left ventricular output and left ventricular stroke volume across the board from the point of delivery to 5 minutes of age, and the heart rate drops from delivery to just under 160 at 5 minutes of age. This slide here is really just to show that at 5 minutes of age, we can see that there was a global decline in systolic and diastolic function as determined by TDI velocities from the initial echo at 5 minutes to immediately after the cord was clamped. And all of these recovered again by 5 minutes of age. Myocardial performance index, which is inversely related to global function, it worsens as well at the time point immediately after cord clamping, but then again returns to baseline in all areas by 5 minutes of age. This image here shows a multilinear regression model showing that the right ventricular output variation across cord clamping was independently associated with variations of ORV afterload or PATI. The left ventricular output variation between time point 1 and 2 was independently associated with variation in the septal mitral annulus A' velocity. So what can we take from this study? We can see that left ventricular output and left ventricular stroke volume increases throughout the first minute of life, right ventricular output and right ventricular stroke volume drops after cord clamping. Right ventricular afterload rises after cord clamping. We can see that TDI-derived myocardial velocities decline after cord clamping, as well as global ventricular performance. These are all transient changes, and they all recovered on the follow-up scan. So what we're seeing here are transient physiological changes in well, spontaneously breathing infants. So looking at some other studies that looked at physiological-based cord clamping, this is in very preterm infants, was a randomized controlled trial, is essentially the ABC2, and it looked at physiological-based cord clamping in very preterm infants. Their aim was to establish lung aeration and adequate pulmonary blood flow and pulmonary gas exchange prior to cord clamping. This was at a median of 5 minutes in the physiological group. And it was defined as oxygen over 90%, heart rate over 100, and an FiO2 of less than 0.4. So what we can see here in the forest plot is that the as-treated analysis of babies in the physiological-based cord clamping arm, they were stabilized much faster, with a mean difference corrected for gestational age of 2.02 minutes. What was also noted, just of note, in the physiological-based cord clamping group was that they required respiratory support earlier. There was a small number of moderate hypothermia noted in the physiological-based cord clamping group, and there was no increase in maternal blood loss. But none of those secondary findings were significant. The ABC3 publication of findings are awaited, and hopefully we can look at those clinical benefits in IVH and NEC shortly. So in 2022, Boode published the findings of a randomized controlled trial assessing physiological-based cord clamping in infants over 32 weeks gestation, and specifically those who were apneic despite stimulation and needing PPV. They were randomized approximately 60 seconds after delivery, and they underwent median cord clamping duration in the physiological-based cord clamping group of 136 seconds. So just shy of 2 minutes, really, versus 7 seconds in the early cord clamping group. The heart rate and oxygen over time was very similar in both groups. So although there was no benefit noted in the physiological-based cord clamping, it is noted to be feasible and safe in this group. So just of note, this data is being prepared for publication, but a further study by our group in Cork looked at the hemodynamic impact of delayed cord clamping following vaginal delivery. So this study hoped to highlight cardiovascular changes in the first minute of life in infants delivered vaginally, and to describe the impact of delayed cord clamping on hemodynamic transition without time constraints, a kind of a pseudo-physiological-based cord clamping, I suppose. Again, this took place in Cork with similar inclusion and exclusion criteria, but as SVDs, and there was 3 targeted echo assessments, again, immediately after birth, the second being immediately after cord clamping, and the third at 24 hours to outrule any structural abnormalities. So these were the results of the study. There was 10 infants included, and of note, the median time of cord clamping was 202 seconds, or just shy of 3 minutes, with a range of 180 to 220 seconds, which is longer than some of the other studies of physiological-based cord clamping. So although the only statistical significant finding was a climb in left ventricular output between time point 2 and 3, or 1 and 2, apologies, we did see the following trends. There was no drop in right ventricular output. There was no negative impact on systolic and diastolic function as derived from TDI measures, and there was no negative impact on MPI or PATI. So again, just to highlight, the median time of cord clamping was 202 seconds. Only LVO increased statistically significantly. However, a prolonged delayed cord clamping did seem to mitigate the negative effects of cord clamping that was described in our C-section cohort, who only had delayed cord clamping of 60 seconds. So there's a potential that something like physiological-based cord clamping could potentiate the negative effects that are seen by prolonging cord clamping. particularly in premature infants, those with HIE. And we look at interest at the findings of the PIN-C trial. We look forward to seeing that, which is a multi-center randomized controlled trial of physiological-based cord clamping versus immediate cord clamping in infants with congenital diaphragmatic hernias. And that is ongoing at the moment. Now, just to finish off with one trial that did look at cord clamping in non-vigorous infants, and this was the MIN-V trial. So the MIN-V trial was milking in non-vigorous infants, and it was a cluster randomized crossover trial that was carried out in 10 multinational sites. So babies who had a gestational age of 35 to 42 weeks gestation were included. These were non-vigorous infants randomized to early cord clamping versus umbilical cord milking. And the primary outcome was to look at whether there was reduced NICU admissions. Now, there was no reduced NICU admissions once the study design by site was adjusted for. However, in secondary outcomes, there was an increase in hemoglobin, there was less cardiorespiratory support in the delivery suite, there was a lower moderate to severe HIE, and there was also less therapeutic hypothermia. The process itself was very fast. 20 centimeters of cord was milked over 2 seconds and repeated on 3 occasions. So the entire procedure took about 10 seconds. So there wasn't much of a difference time-wise between when the cord was clamped in the cord milking group versus the early cord clamping group. So that's really just a quick run through, really, I suppose. Some food for thought is that there are issues with animal studies. Animals are very different to infants in that the placentas are different. We could see from the flow studies that the IVC enters the diaphragm differently, which means that we need to keep this in mind when we are interpreting results. So although we can learn from animal studies and they provide the groundwork for research in this field, we believe caution should be taken when extrapolating information due to the various anatomical differences. So there's no clear evidence at the moment in delayed cord clamping or a non-time-based cord clamping. However, our cohort of SVD infants that were well and spontaneously breathing, delaying their cord clamping for as long as 3 minutes seemed to mitigate the physiological effects of cord clamping as seen in our C-section groups. So perhaps future studies should move away from the animals models and focus on another group, potentially preterm infants. And in fact, we are hoping to report our findings of the Matinee 2 study, which will look at the impact of cord clamping on hemodynamic status in preterm infants. So watch this space, and thank you all for your attention this evening. I will hand you over to the panelists and to the audience themselves for any questions, and Professor Dempsey and myself look forward to answering them. Thank you very much.
Thank you so much, Dr. Bussmann, for this amazing presentation. I will open the floor for the audience to make some questions on the Q&A box. In the meantime, while we don't have questions, I will just make one question for both of you, the speakers. So there is an interesting study by Dr. Blank using lung ultrasound during the initiation of breathing. They reported that approximately 90% of the infants had air entry to the distal lung around the 5th breath. So what are your thoughts on changing the time or guiding the cord clamping from time to a certain number of breaths, perhaps?
I suppose I'll try answer this a little bit, Jean, and you can jump in as well. But I think the most important thing that I've gathered from looking at all of this and from our studies here in Cork is I don't think a specific number should be used. And that's both for seconds to when to clamp the cord to how many breaths a baby should take before you clamp the cord. I know we all love having one figure, and if we can stick to it, that makes life easier for everyone. It makes life easier for the midwives. It makes, it just is much simpler. But I suppose if we look at the other studies, which looked at the flow in the umbilical cord, we saw that even palpating the cord to feel for pulsations, sometimes actually looking at it, there was still flow ongoing, or sometimes even there was flow coming back from the baby. So perhaps something like a bedside ultrasound or bedside echo, looking at how the right ventricular output is responding to drops in pulmonary pressures, perhaps that would be something that would be a little bit more physiological rather than one number of breaths or a specific number of seconds as to when to clamp the cord. And I'm open to suggestions about this, but see what you think.
I might jump in there if that's okay, and then maybe pass it over to the moderators. But I think that's probably one of the greatest challenges, in a sense, is trying to determine when babies have aerated their lungs. And I think it's something that we struggle with. We try to apply subjective assessment to it, and we've seen that in the Vent First trial. I think one of the subgroups of that was looking at babies based on a clinical assessment at 30 seconds, I think. Or maybe Anup can correct me, or somebody can correct me on how that was absolutely determined. But I think that's one of the critical issues. And we have tried, Neidin introduced the Matinee 2 study. That was a trial of looking at the impact of clamping in more preterm infants. And we managed to enroll about 50 preterm infants into this study. And as part of it, we tried to determine, or at least assess, the concept of poor adaptation and good adaptation. And they were based on criteria such as the baby is breathing effectively, and you can tell me what effectively means, but breathing. We included a heart rate and APGAR score as part of the concept of adaptation. And that breathing assessment was again at 30 seconds, to be somewhat consistent with the Vent First trial, actually. I suppose it would have been lovely to have the data today. We have a very good statistician who is still working on the data, but of the babies, approximately 20 out of the 50 had poor adaptation and 30 had good adaptation. So we're looking at the impact then of the impact of the timing of cord clamping in this group. Now, it is time-based, it wasn't physiological based, but again, it's consistent with what I guess is current practice. So it'll be interesting to see, is there a negative impact on RVO, on PATI, on LVO in babies who have poor adaptation, and I guess further support the concepts of physiological based cord clamping. To address the issue that Neidin brought up in terms of the section and the vaginal deliveries and the differences, or at least, you know, these are physiological impacts. We're not saying they're bad for you. They're what happens physiologically when the cord is clamped at a minute in babies who are delivered by cesarean section, all of whom are breathing well. So these are transient physiological phenomena in well babies. When we looked at it in vaginal deliveries, and you may ask, why was the number smaller? Well, actually, it's a lot more difficult to do 3 echoes when the mum is holding a baby following delivery. You know, it is a bit challenging. So to get in there, do the echo, have the cord clamped, do the echo again, take the baby away to do the echo. You know, so we struggled with numbers. But we got, I think, 10 in total. But the interesting thing was the timing was greater. So it was almost 3.5 minutes or thereabouts when the cord was clamped. And the interesting thing was the RVO was increasing. There wasn't a negative impact on any of the measures that we described in the cord clamping in cesarean section babies who all had it at a minute. So I guess just waiting that period of time, one is hoping that there's a smoother transition and less of a negative impact, as in the physiological impact of clamping the cord. And remember, all of this is, they're normal babies who are breathing well. We haven't ventured into the, you know, poorly adapting term infant or poorly adapting preterm infant as of yet. So that's a long-winded answer to your question about long ultrasound in the delivery room and assessing aeration.
Thank you. So I'll let Sharada Gowda to make her question.
Yeah, thank you so much. That was a fascinating presentation. I actually had a logistical question about the 3 echoes and also how, what kind of, views are you doing, and how quickly is a study done, and is it a protocol? Just seems like so much needs to be coordinated. So kudos to you on doing it. I was just curious if how you
Yeah, I guess
navigated it.
Yeah, there was an awful lot of thought went into the process, and quite a bit of simulation went into the process prior to actually getting into the delivery room. And we had a very, very experienced Italian trainee with us who was incredibly slick with his echo skills. And actually, the second study that we've done on the preterm infants, it's another Italian trainee who's incredibly slick at obtaining images. And we spent a bit of time beforehand trying to decide what were the optimal views, and ultimately came down to 3 views. And he was able to get the echoes done really promptly. And I mean, within 40 seconds, get these. I'm telling you, as in, they're very targeted. The echo that was done at 5 minutes was a little bit longer, and then they all had a structural echo done at 24 hours, or if there's any concerns, they had it done sooner. So again, it was planning, a lot of interaction with our midwifery and theatre staff and obstetrical staff. And I suppose, not to be flippant about things, but I remember standing in the delivery room when the first echo was being done, and Roberto, the Italian trainee, I could see the blood drain from his face when he was about to get into the obstetrical, if you will,
Field.
area.
Yeah.
So yeah, he was really nervous and frightened. And I actually, when we first thought about doing this, he thought I was mad. He thought like, well, we can't do this. But actually, you can easily do it. Well, easily is probably an unfair statement. It takes time and organization. But we were able to replicate it, I guess, in smaller babies. It is a bit more challenging in smaller babies. And our aim was to get down to as immature as we possibly could. But in actual fact, as part of the study, I think the range was somewhere from 26 weeks to 35 weeks, with a median gestational age of 32 for the more immature babies. And it's more difficult to capture all of those immediately post, and whatever about the 5-minute one, it's that more straightforward. But for some of the preterm infants, there's a concern about hypothermia, etc. So we didn't want to leave babies on the mum for an extended period of time to try and capture the second scan, etc. So not all the 50 babies had every single 1, 2, and 3 scans performed, but certainly over 60% of them would have had first and second scans done. But it's organization, planning, and simulation, and getting everybody on board, basically.
Great, thank you. We have some questions from the audience coming through. So the first question is, and this can be open to the panelists as well as the speakers. What do you think about the use of NIRS for monitoring cerebral blood flow after umbilical cord clamping?
Well, I think there's a couple of ways to answer that question. I mean, Anup has done some really excellent work in the delivery room looking at the impact of milking and delayed cord clamping and its impact on cerebral oxygenation as opposed to cerebral blood flow, I suppose. There are very few studies that have looked at cerebral blood flow in the delivery room. I think Bernd Ulsberger, a number of years back, looked at the impact of sustained inflations on cerebral blood volume and the potential negative impact of sustained inflations in that. But COSCOD was a study we were involved in, which was a delivery room trial looking at cerebral oxygenation in addition to routine monitoring. And there is a paper being prepared on delayed cord clamping versus, different timings of clamping and cerebral oxygenation. So I think, we wait for that to come out to give us some insight into that. And there are probably others on the call who will have further insight into cerebral oxygenation. We have looked at cerebral oxygenation before, but more on the impact of different oxygen strategies in terms of titration strategies. And it was an era where there was a variable cord management when we were doing that particular study. It was inconsistent. Some had delayed, some had more immediate cord management strategies. Anup has his hand up, so I guess.
Yeah.
Yeah, sorry. I have a few things. First, Neidin, I thought you did a fantastic job just going through a lot of the physiology, and I think it's really great to be able to compare sort of the animal physiology alongside with the human, and the differences. And again, to commend you guys. I don't think anyone's going to ever replicate the echo type of study you did on the cord. I think just having tried to even gone in there to do other monitoring studies, I think is quite challenging. But I just wanted to get a couple of these questions out just for you guys and the panelists too, because look, I struggle with just generically throwing out the word physiological based cord clamping. People love to use that and say, yeah, time is terrible, etc. I looked at the chat of the people here. One of the audience members, his name's Hassan Kilitz from Turkey. And, he looked at this idea, which one of the panelists called, once the baby starts breathing, what if you clamp the cord, and call that physiological based cord clamping in healthy term babies? Compare that with a 60-second delay, compare that with immediate. And what happened was the babies with physiological based cord clamping had their cords clamped in 15 seconds because they were breathing. And that's fine. And hemodynamically, they may be fine, but then we're missing the fact that, well, there's a placental transfusion occurring in these babies. So lo and behold, even though there were no adverse outcomes, the babies had higher crits and et cetera downstream. And I think the big thing we miss in the animal studies, yeah, the anatomy is different, but there's no real placental transfusion happening in those lambs, right? They're anesthetized, and normally in lambs, when they deliver, there's no cord left in the blood when they deliver in nature. So to try to do things where you either force the blood in with milking or you're trying to ventilate over some period of time, you're accounting for some of the hemodynamics that you can't measure, like in humans, we can't do. I mean, maybe, Gene, you'll find a way to do carotid flows in these babies at section, but we're really not going to be able to get invasive enough to do those things. So we're trying to extrapolate that one thing, but we're missing the whole thing about placental transfusion. If you look at all the human studies, including the one you just showed, the one thing didn't comment on, but it was statistically significant, it's been true in every human trial, is the general drop in heart rate with delayed cord clamping. So as these babies are getting more preload, their cardiac output's going up, but it's not because of heart rate, it's actually dropping because of this extra volume of blood. And that's not happening in the animal trial, so we can't extrapolate those sort of differences. So again, this is not evidence-based either, but my take with using the physiological-based method is to say, look, these kids need some set amount of time on the cord. You have to, I was just on call last night and getting my OBs to say, look, just wait. But the idea is, what I would take from the animal data from Stewart and Graham is that the sicker kids, we actually have to push them, which is counterintuitive, to go even longer. So that kid who's limp and terrible, you still got to go to 60, but you might actually have to go to 2 or 3 minutes because that kid needs time. You could do a whole talk on intact ventilation, et cetera, and ventilating these kids and having the right sort of physiology for that. But really getting those kids more time on the cord is probably okay, but it's hard to do a trial that way. But I think the idea that, time-based is terrible, a physiological-based way to go, we're just sort of pulling words out without any sort of giving meaning to clinicians on how to use it. So that's one take, and I'd love the panel members to talk about it. The other thing is, I do think the idea of looking at ultrasound and lung aeration or even doing an echo sounds great to look at the timing of the cord, but I think, Neidin, you and Gene should sit down and say, do we really think outside of a study we'll ever bring an echo machine into the delivery room and say to our OB, okay, clinically, all right, hold on, wait, okay, now the LVO is better. Oh, all right, okay, go ahead and clamp. I mean, I just think it's a stretch. And I think what we need to do is find some more simple clinical markers, because I think at the end of the day, our research, we're trying to make it so it can be generalizable to everybody. For the people who don't have echo, for the people that have no NIRS, cardiac output monitoring, whatever you want to call it, and just keep it really straightforward, but say, what can we look at on these kids? So using the data, you guys are doing such a great job with in finding these nuances between mode of delivery and other things, and this idea of different durations. Can we then sort of pull that together to sort of tell people on this, all these people on this chat and the audience to say, here's where we really think you should look at the physiology, but it's not as invasive or dynamic as we are, but we're trying to apply that. So, okay, I knew I was going to say a lot. That's why I was cutting in line here to talk. So I'll let you guys I'll shut up for a while.
Could I say two things just to address what you said? And it's actually to fully agree with everything you've said, So, but first of all, in the C-section study, and we didn't present the data, when the cord is clamped, the heart rate's drifting down, as you said. When the cord's clamped, there's a transient increase.
Goes up, right.
Yeah, transient increase.
Sure.
The minute the cord's clamped, which is a reflection of RVO or of reduction in I think percent of transfusion related to the clamping. It's transient and it comes down, but it's very clear and it's obvious in every baby. That's what was happening.
Right.
The second thing around the unwell baby, I agree. I think the worst thing you can do, I think, is clamp the cord, because we're seeing these transient physiological normal changes that happen in well babies, and you're actually going to make things worse if you're not well and not transitioning, and you do it. I mean, that's what I take from the well babies and these normal physiological changes. You're getting, I won't describe it as stunning the heart, because that's being very melodramatic about things, but there are transient changes. They happen. And if you're not adapting well and you go and do this, I think you make things worse.
Yeah.
So I think the challenge for us all, and actually I see Bernard has posted a question about end-tidal CO2. And I think, different ways of trying to assess how babies are adapting, I think is essential. And yes, the Boode study, where they used end-tidal CO2 as a marker of lung aeration, I think things like that give us a greater insight into how well that baby is adapting. But I agree fully. I think, the language around physiological based is variable, and I think for many of us, physiological cord clamping, has happened. It doesn't need to be 10 minutes or 7 minutes or 5 minutes. It can be sooner if we're happy that baby has transitioned. Yeah, I fully concur with what you said.
Thanks.
I think it may be just a play of words, physiological versus delayed versus, spontaneous breathing. Do you think with the current state of knowledge that we have today, we still need to give some kind of direction to the obstetrician who's actually on the other side? Do we think, what is the best evidence to give that instruction to that person who's going to clamp that cord? And are we there yet to give that instruction?
You talking about the guidelines or what? Sorry.
Yeah. In terms of just guidance, when do you stop? When do you right. Clamp?
I mean, I think the good news, sorry, I'm jumping ahead here, but I think, the good news is the guidelines are finally pushing out the duration longer. I hated the fact they wrote 30 to 60 when all the trials that were using 30 were like in the late 80s, and no interventional trial ever calls 30 seconds delayed cord clamping. And I often say, when I talk to people, that's not delayed. That's like early cord clamping versus immediate, and I think, so now the new guidelines from ILCOR will say 60, and every, the European consensus statement, others will sort of adopt that as a minimum. But even you look at in Sweden and other places, they've adopted like 3 minutes as a baseline, but I think that's still hard to do in the early preterm infants. So I still think your guideline should say aim for 60. And the idea that if you want to get into the physiology, let those sicker kids try to have more time, find ways to provide support on the cord if you can. Again, even though we're not going to have the great, and a lot of the trials aren't published yet, even though they may not show definitively that, you know, providing support on the cord is better, we know that it just makes sense physiologically giving those sicker kids more time. So you start with the time and then add to it. I think that's what I do, and that's my practice, but I should let the others sort of talk about how they implement this sort of in their own units. Or you, Poorva, what you guys do in, you know, Toronto.
We go with the 60-second kind of guidance in our unit.
And we literally
Okay.
stand over the obstetricians, well, when I say over, at the end of the bed and encourage stimulation. And, you know, you're not just shouting from the resuscitator, and I'm sure it's the same in every other unit as well, but definitely getting involved and being there and watching. It just provides a little bit of reassurance to the obstetrician who's there with the baby, which is only fair. And if that can be extended, that would be great. But I think at the moment we're still happy to be able to get the 60 with them.
I see Willem has his hand up, and then Tina as well.
Yeah, thank you. First of all, I want to thank both Neidin and Eugene for a perfect overview of this topic, and I congratulate you that you can do all this research. It's so it asks a lot of all the researchers, and it's really fantastic that you've done it. First of all, I want to react on the question. I try to be on the OR and try to speak to the obstetrician, wait, and just be there and ask them and just tell them, don't worry, I'm here, it will be okay. And it's not 30 seconds, it's 60 seconds, I look at the baby. We're also participating both in the ABC3 trial and also in the PINK trial. So that makes it more easy for the obstetrician to rely and to trust that it's safe to do. But it's really trying to convince them that it's better. And of course, we have to show them as good as possible from the randomized controlled trials, and that's still difficult to do. I fully agree what Anup has told about just one number or something like that. It's difficult. We have to be pragmatic. However, it's always difficult to have a too pragmatic approach. For the healthy babies, it's okay. I don't think it will matter a lot whether it will be 60 seconds, 80 seconds, or whatever. However, for the more complex patients, it's always we can't simplify the complex physiology or pathophysiology in those patients, and so we have to try to find out what's the common way. How can we advise to handle them? But it's always difficult. We try to be very simple and okay, this is the only way to go. It's so individual differences. That brings me to just one question regarding the intriguing research being done with all the echoes, and it was remarkable. There was no clear distinction between the two approaches for the outputs and by the echocardiography. I'm always thinking, well, how accurate is the echocardiography? Plus minus 30%. And if I see there was only the left ventricle output, a significant difference, but that's only 11 mLs per kilogram per minute, so hardly clinical relevant. If you show the charts of the changes in output with the decrease, increase, etc., it's the average of all the different patients. I was wondering, do all patients show the same pattern, or is there a large inter-individual difference? So one baby got an increase and then a decrease, and the other is a decrease and then increase, or is it very similar in all babies? So do we really see the physiology, and are we researching the physiology, or is it reflective of our inaccurate way of trying to measure these outputs? Sorry for the long question.
I guess I could maybe address that to some extent. the section study, which had 46 or 7 babies, in general, and I can't be any more accurate than that at the minute, I'm afraid, but in general, the trend was the overall trend, and it was the same per baby, essentially. Can I tell you exactly the number? I can't, but I can find it for you and I can get it for you. What we have seen with the preterm group, and sorry, the vaginal delivery was very similar, and I take your point absolutely. What's the bloody difference, like 11 mils is no difference. And I guess the point of the vaginal one was actually that the RVO was actually making its way up. It hadn't come down. I mean, that was in a sense the point of the vaginal one. But I think the reflection that the LVO at essentially 3 minutes or more was actually, that was it. There wasn't going to be, if it was done a minute and a half or 2 minutes beforehand, then maybe you might have seen a lower one. But in fact, the fact that it's done at 3 minutes, I think things have evolved. They are where they are. With the preterms, and the analysis is being looked at now, you are seeing variability in the T1 and T2 measures from individual babies. You're seeing quite a marked variation in heart rates. Some babies with heart rates of 40, 60, while the echoes are being done. We turn the volume off to not frighten the obstetrician, when we're there. And so, and actually, occasionally, when you're doing the echo, you're stimulating them to an extent. So, but it'll be interesting to look at that in the preterm population, Willem, and thanks for raising it.
Well, again, applaud you for the excellent, because it must be very difficult to get the echoes in this situation with vigorous patients, with not vigorous patients. Congratulate for doing this.
Thank you.
Tina has her hand up.
Thanks. Yeah, I also want to congratulate you, Neidin and Eugene, for great work and presentation. In the conversation, one of the things that has come up in our unit over the last few weeks is that the obstetricians are asking us to be doing like the stimulation and care during the delayed cord clamping. So I guess over the last few years, even there's been a little bit of variation where some people might jump in and they're scrubbed in a C-section and they might just jump in and do it. And the obstetricians have found that to be really helpful. And so they are actually asking us to do that all the time. So that we'll just handle stimulation, suctioning, whatever we think the baby needs during that time, and then tell them okay, cut now, or whenever we say to cut. And I don't know, we're just starting it, so I don't know how it will go. But I thought that was a really unique take on how we could handle things, and I think it's a good way forward in terms of at least us being really involved and really helping make the decisions.
I fully agree, Tina. It's we're currently finally transitioning to utilizing the live start, but the main reason for using it is actually for us to be there, and to reassure, in a sense, the obstetricians. And I guess one of the issues is just ensuring that people are adequately trained in its use. And a number of years back, we did a small pilot study on its use, and it worked very well. Again, with a lot of training beforehand. But even in the absence of having some sort of table, I think being present, scrubbed in, is probably a great idea, If anything, it's just to reassure the obstetrician and to stimulate and, like you said, suction if you have that available, and mainly to catch the obstetrician's hand to stop him from putting a clamp on the baby's cord. So anyway, yeah. We need to find something to keep them occupied for the 2 minutes or whatever, we need to, I don't know.
I mean, that's a great point. And one of the reasons behind their request was because they have their own QI project to try to decrease postpartum hemorrhage. And so, so that's their goal, is to try to have their minds occupied in other ways to try to pay attention to postpartum hemorrhage, and that we can worry about the baby, which I think makes a lot of sense.
We do have a couple more questions from the audience. Does the fetal heart rate monitoring or non-stress test have any impact on the RVO before and after clamping?
I guess I can't.
Go on ahead, sorry, Jean.
Sorry, Neidin, I can't answer that in terms of the term babies, because they were all elective cesarean sections. They weren't emergent cesarean sections. But what is clear in the preterm group that we've looked at are that there are a certain proportion where they were delivered emergently, and some of those were CTG abnormalities. So I think that's, again, a really interesting point to raise and something that we will look at.
I may ask a question, and this is open to all the panelists. There has been some kind of discussion towards again delaying cord clamping for the infants with congenital heart disease. What's your take on that? Especially for the cyanotic heart disease babies.
If it's okay, I'll just give our perspective, because we have a really big congenital heart disease population. I think there are a few that we should probably not be delaying, who are, more likely to need really urgent care. So we tend to say not to delay for transposition with intact ventricular septum, or if we're worried about a hypoplastic left heart with having not a adequate septum, we would not delay in that situation. There would be some people in our group who would extend that to more babies, but to me, I think those are the two that you might really have significant problems in the early transitional period, and that we would really want them to be, just managed as fast as possible.
Hey, Sharada, do you have anything to add to that?
Yeah, along with what Tina mentioned, I think it is not the lesion itself that dictates whether or not this patient, the baby, receives the delayed cord clamping. It's really the physiological clinical status at birth and delivery. And if you already know there is a restricted atrial septum or a ventricular septum, or if it is a PIVS, yes, those babies tend to be much more sicker at birth and perhaps not be helped by the additional blood that babies are going to get. If it is any other lesion that the patient is vigorous and the baby is vigorous, I think that there's the benefit as well. So we do tend to have the CICU resource person in the delivery room as well. So there's more than one person that's monitoring the clinical status of the baby. So there's the neonatology team as well as the critical care, cardiac critical care resource attending that's in-house in the delivery room that's guiding those interventions.
Anup?
Yeah, this would have been a good pro-con debate panel question. So we're actually advocating for the opposite. We're doing a trial with Carl Boxett nationwide to look at 650 babies with critical congenital heart disease, so an FDCS score of 3 or greater. So those are transpositions, kids with restricted septum. The idea being that those kids are going to definitely go for surgery. They're going to have excessive post-op sort of recovery, and Carl had done a small pilot at nationwide of about 50 babies, showing that in fact you reduce the need for even needing blood transfusions in these critical cardiac patients if they got delayed cord clamping. So because interesting, there are some issues with equipoise, we're comparing 2 minutes or greater in the intervention group to 60 seconds or less. And so we're working with some centers in Canada as well as in Europe, but I think the question is it really harmful, or in fact, are there benefits? So I think, as you heard from Tina and Sharada, maybe there are some units that are clearly still doing early cord clamping in some of those patients, but you have to also argue, like, well, in utero, clearly they're not having issues because they're on the placental circuit. The question is whether this additional blood volume is really necessarily harmful or not. Even in kids that need to rush to the cath lab, it's not like they're going 60 seconds later and something's going to deteriorate in that period. So anyway, that's just our other opinion sort of on that side. But I think it's why it's good to study it. Then you can actually say, man, who was truly affected or benefited from delayed cord clamping? So it's a great question.
Yeah, and absolutely. And I think because there is the cerebral injury as well that accompanies these kids as well, and whether keeping that circulation going potentially would benefit the cerebral blood flow. I think that's again another big question.
I would still be hesitant to say the same thing about, because transposition physiology is so much more different than any other physiology. Here, the brain, prenatal brain, is really not getting oxygenated blood across the PFO to the left atrium ventricle and because the head and neck vessels are truly getting the deoxygenated blood here. So I don't know if postnatally continuing this would really truly help in any way. So that's probably the one thing. So yes, we are actually part of the Cord CHD trial as well. So I'm really looking forward to enrolling patients and getting started. I think finally our IRB should be ready pretty soon. So
right, and as you know, Sharada, we're going to risk stratify the lesion. So
yeah,
we'll have like a good range of like the really severe, FDCS scores of 5 and greater, and then those 3s and 4s that are maybe like the TETs and restricted, pulmonary restrictive type of patients. So I think ultimately we need to just answer that question, because I think there's a lot of variability if you survey people on cord management for CCHD kids. CDH babies, as William mentioned, there's the trial in Europe with the PINK study and others. So I think these congenital anomaly studies are important because they get excluded from most of our other trials. So
yeah, absolutely agree with that. I think the CDH has a Shone's variant that is so uniquely different than the multitude of congenital heart diseases that you can see. And again, I'm the co-PI for the Cord CHD trial, so it's just one of those things where I want to really study the science behind it and see which population this helps, and want to make a difference. And yes, it's to be continued and to be studied further.
There's a question from the audience. If you are okay, I will ask that. So in case of general anesthesia during C-section for the mother, should we be cautious with the duration of cord clamping?
I can jump in and others can, but we included mothers that receive general anesthesia in our trials only because, the theoretical risk of anesthetics really depressing a child who could get support, I think, does not outweigh the risks of early cord clamping. So we argue that you're going to necessarily harm the child more by trying to clamp sooner than trying to worry about a theoretical risk of some anesthetic. Now, does it happen? Probably to some degree, but I don't know in those situations if the fetus is already getting lots of anesthetic, like we see this with other medications as well. I don't know if 30 to 60 seconds of additional cord clamping time creates a larger load, right? We haven't seen that in other types of things like RH incompatibility, et cetera. So I don't know if that's truly been shown. That's just my take on it.
Okay, great. I think there are a couple more questions, but I'm just aware of the time here. So thank you again, Neidin, for the excellent presentation, and Eugene for also helping Neidin there as well as providing your insights into this fascinating topic. And I also want to thank you for all our expert panelists for providing their opinion and their insights as well. So thank you, everyone. And we'll see you again in the next NHRC presentation.
Thank you, Poorva. Thank you.
Thanks.
I just wanted to say a final big thanks and well done to the all the fellows that were, you know, at the bedside doing these echoes as well. They did a really excellent job, like Gina said. So well done to those. Thanks, Emil, for having us today.
Thanks, guys.